Good evening, everybody. Welcome. Thanks for joining us tonight. My name is Michael Potter. I'm a hand and upper extremity surgeon with the Valley Ortho Group. I'd like to spend about 20 minutes tonight talking about some common hand and wrist conditions that bring folks into my office. And be happy to take any questions you have at the end of the presentation. So I'm meant to remind you to use the Q&A function if you'd like to ask a question. Any unanswered questions we'll try and answer by email. Please fill out the survey at the end, and link to the recording will be sent out tomorrow. So I'd like to spend about 5 minutes each on 4 major topics. So these are common hand and wrist disorders that affect people of all ages. With the active population that we have out here in the Valley, I also see and treat a wide variety of hand and wrist fractures. I'll be giving a talk later this fall that's more focused on fracture care and fracture prevention as we head into the season of snow and ice. So tonight we're going to talk about these 4 topics: nerve compression, tendinopathy, arthritis, and Dupultron's disease. So when folks think about hand and wrist pain, I think often the first thing that comes to mind is carpal tunnel syndrome. Carpal tunnel is certainly one of the most common conditions that I see and treat. So what is it? Put simply, it's compression of the median nerve where it enters the palm of the hand. So what kind of symptoms do patients experience with carpal tunnel syndrome? By far, the most common symptom is pain or numbness in the fingertips. You can see in the blue shaded portion in the image on the right, the distribution primarily thumb and index and long finger. In the early stages of the disease, symptoms tend to come and go. As the disease becomes more advanced, then you may start to see weakness in the muscles at the base of the thumb, more constant numbness, or even atrophy or loss of the muscle at the base of the thumb. Initial treatment for carpal tunnel syndrome is typically non-surgical. For patients with early symptoms or symptoms primarily at night, then oftentimes a wrist brace that keeps the wrist in a neutral position at night can take pressure off the nerve and help improve symptoms. For patients that are a little further along with more swelling or inflammation around the nerve, a steroid injection in the office can potentially help that swelling go down to relieve the pressure on the nerve. Nice thing about a steroid injection is it's an office-based procedure. It comes with no downtime, so there are plenty of folks that opt for that. For patients that don't find adequate relief with non-surgical treatment, then surgery for carpal tunnel will reliably and permanently relieve the associated pain and numbness in the fingers for the vast majority of patients. So what's involved in carpal tunnel surgery? Surgery is fairly straightforward and patients tend to recover rapidly. Surgery is done as an outpatient procedure. We inject some numbing medicine or some local anesthetic at the base of the palm. You can see a typical incision there in the picture on the left. Make an incision over the carpal tunnel, and then underneath the skin there's a ligament called the transverse carpal ligament that's putting pressure on the nerve, and just make an incision in that ligament to take the pressure off. So the procedure itself only takes about 10 or 15 minutes. Post-operatively, I have patients keep a bandage on for 3 days. After 3 days, they can take the bandage off and get the hand wet under running water. Patients can use the hand for light activities right away. I just ask that they avoid any heavy activities for about 2 weeks after surgery. Around that 2-week mark, we see each other back in the office, take stitches out, and let folks go back to doing whatever sort of activities they want to do. So the other compressive neuropathy that I commonly see is what's called cubital tunnel syndrome, which involves compression of the ulnar nerve at the elbow. So this is that funny bone nerve that you can accidentally bump on the inside of the elbow. Patients with cubital tunnel syndrome will have similar symptoms to patients with carpal tunnel syndrome, but in a different distribution. So you can see there on the right kind of the blue shaded area that's innervated by the ulnar nerve. So patients with this condition will get numbness or tingling in the ring and small fingers. A lot of times they'll describe the hand as feeling clumsy or slow, may have difficulty with buttons or typing or other fine motor activities. Like carpal tunnel, in the early stages, the numbness and tingling, the other symptoms, they tend to come and go. As the disease becomes more advanced, that's where people start to see muscle weakness or even atrophy, more permanent symptoms. As with carpal tunnel syndrome, treatment initially for cubital tunnel syndrome is typically non-operative. some patients will use a brace or a padded sleeve on the elbow that protects the nerve and keeps them from bumping and irritating the nerve all day long. Sometimes simply activity modification, avoiding positions that put the elbow in prolonged flexion can help take the pressure off the nerve. For patients that continue to have symptoms in spite of non-surgical treatments, or for patients with more advanced disease with weakness or constant numbness, then surgery is sometimes required. So surgery for cubital tunnel syndrome has a lot in common with surgery for carpal tunnel syndrome. It's similarly done as an outpatient procedure. It involves a small incision on the medial side of the elbow, on the inside of the elbow, where the nerve is. And as you can see highlighted in that diagram on the left, there are several common sites of compression where that nerve runs past the elbow. And basically in the same way that we release the transverse carpal ligament to relieve pressure on the median nerve, in this situation we release those tight bands of tissue on the inside of the elbow to take pressure off the ulnar nerve. Recovery is similar, kind of that same 2-week timeline of light activities only, and then stitches come out around the 2-week mark and patients can go back to doing whatever activities they desire. So at this point, I'll move on to our second topic and talk about tendinopathy. So just from a definition standpoint, a tendon is a structure that connects a muscle to bone. And so in the hand and wrist, the tendons are the major players in moving our fingers and helping position our wrists and hands to accomplish all the things that they can accomplish. Most of the muscles are actually up in the forearm, and so the fingers are articulated primarily by tendons that cross the wrist and go out into the fingers, as you can see illustrated there. In total, we have more than 24 different tendons to each hand, or exactly 24 different tendons to each hand. And in theory, you can get tendonitis or tendinopathy of any of those tendons, but I'm going to focus on 2 of the more common conditions. First is trigger finger. Trigger fingers are common in patients of all ages, but I start to see them more frequently as patients get into their 40s and 50s and beyond. Symptoms you can see listed there: pain in the base of the finger, often accompanied by some form of mechanical symptoms, a sticking, catching, or popping sensation with finger range of motion. So what is a trigger finger? Basically what happens is you have 2 tendons to each finger that bend the 2 knuckles out in the finger. And for whatever reason, you get some swelling in the tendon. That tendon runs through some tight bands of tissue called pulleys, which hold it down against the bone and sort of keep it in position. And what happens is basically that swollen portion of the tendon, sticks or hangs at one of those pulleys at the base of the finger, or a structure called the A1 pulley. Treatment for trigger finger can either be observation or steroid injection or surgical release. For patients that have some milder symptoms or find their symptoms tolerable, this is a safe condition to live with. The tendon isn't going to rupture or break, but it won't necessarily get better on its own. For patients who are more symptomatic, I almost universally suggest starting with a steroid injection in the office. Unlike steroids used for arthritic joint pain, in this situation, there's excellent data from large groups of people that steroids are often curative for this condition. So if you look at large groups of patients, then up to 75 or 80% of people, so 3 out of 4 or 4 out of 5 people who have a trigger digit will have resolution of symptoms with steroid injection alone. For folks who don't get better with injections, then surgery is a reliable option to fix this condition. Surgery has a lot of similarities to carpal tunnel surgery. It's done under local anesthesia. It's a quick procedure, maybe 10 or 15 minutes. Basically make a small incision at the base of the finger and then just release that band of tissue, that A1 pulley where the tendon is hanging up. Recovery is real similar, that 2-week time frame that we've talked about a couple of times already. So the second tendon condition or tendinopathy I'd like to talk about is what's called Quervains tendinopathy. Sort of a mouthful, but basically what it is irritation or inflammation of 2 of the tendons that run to the thumb. Patients will usually get pain in the base of the thumb or on the thumb side of the wrist, exacerbated by lifting or by heavier activities. And it's something that actually we see quite commonly in new mothers, the thought being that the tendon gets stressed or inflamed as mom is constantly picking up the new baby. Here's a more schematic illustration of the Quervains tendinopathy. You see the 2 tendons there, and where they run past the wrist, There's a tight band of tissue called the extensor retinaculum that can put some pressure on the inflamed tendons and cause pain. As with some of the other conditions that we've talked about, initial treatment is typically non-surgical. Some patients will have adequate relief of symptoms with just a brace or a temporary period of immobilization of the thumb. It can be hard for some folks because the brace gets in the way of daily activities. But just like with trigger finger, if we look at large groups of patients, then many patients will get better with 1 or 2 steroid injections and won't end up needing surgery at all. If non-surgical measures are unsuccessful, then surgery is a reliable fix for this condition as well. Surgery for Quervains is conceptually similar to some of the other things that we've talked about. Problem is basically the tendon is swollen and inflamed, and it doesn't fit cleanly through a tight tunnel of tissue. In this case, what's called the first extensor compartment at the wrist. And so under local anesthesia, make a small skin incision, make a relaxing incision in that extensor retinaculum, that tight band of tissue at the wrist, and then that relieves the pressure on the tendons. Recovery, again, is sort of that 2-week recovery. Bandage for 3 days, use the hand for light activities right away. Stitches are in for 2 weeks, and then at 2 weeks, stitches come out and patients can go back to all of their normal activities. Move on to our third topic, which is hand and wrist arthritis. I think many people are familiar with the symptoms associated with arthritis. In this case, pain, stiffness, sometimes swelling, sometimes, even as arthritis gets more severe, even deformity of the fingers or the wrist. It's a disease that tends to wax and wane, so patients will talk about having good days and bad days. There's many small joints in the wrist and the fingers. It can affect many of them, but I'll talk about some of the more common places in the wrist, in the joint at the base of the thumb, and some of the small joints in the fingers. Treatment for arthritis is directed by how symptomatic it is. So we have a variety of options that you can see listed there, and typically what we'll do is start with the less invasive or the simpler options. And if that provides adequate symptom relief, then we continue with those. If simpler options don't provide adequate relief, then we sort of walk our way up the ladder as we need to help patients feel comfortable and stay as active as they can with their hands. So one of the common places that we see arthritis in the hand and wrist is in the joint at the base of the thumb, what's called the thumb CMC joint or the thumb basal joint. The thought is that the thumb has to work harder than the rest of the fingers, and over time all that extra work causes the cartilage surfaces to wear out on the end of the bone. Patients with this condition will typically have pain with pinching or gripping activities. You can see the person there trying to open the jar lid. Or folks will talk about turning a doorknob or turning a car key, or common things that provoke symptoms. There are many, many patients that get by for years with some form of functional bracing, plus or minus sort of intermittent steroid injections if they have flares of arthritis. If it does get to the point where it's unmanageable with non-surgical treatment, there is an excellent surgical procedure for this. So what's involved in that procedure is basically the arthritic bone at the base of the thumb, a bone called the trapezium. That bone comes out, and then we use a couple of the ligaments or the tendons that run in that area to create a sling or a hammock underneath the base of the thumb to hold that space open. And over time, as the body heals from that surgery, body fills that space in with a little pillow or a little cushion of scar tissue. So rather than having that bone-on-bone arthritis, the thumb is in a good position and sitting on a softer, more cushioned surface. So long-term, patients do really well with this procedure, reliable pain relief, and it also preserves all of the motion and the strength in the thumb. It is a bit longer of a recovery, more of a 3-month recovery as compared to some of the other procedures that we've talked about. So I typically recommend that patients exhaust sort of all the non-surgical options before considering this procedure. So for wrist arthritis, there are a variety of surgical options, and typically we'll tailor the exact details of the procedure to the sort of precise anatomy of the individual patient's arthritis. In this case, you can see the preoperative x-ray of this patient who had an old ligament injury here that is starting to develop some arthritis in the wrist. And in this case, this patient is a candidate for what's called a partial wrist fusion or partial wrist arthrodesis. Nice thing about that procedure is it's a durable pain relieving procedure, but it also preserves a fair bit of the motion in the wrist. For patients with arthritis out in the fingers or out into the smaller joints in the fingers, you can see this patient has an arthritic PIP joint. Then they actually make the material is called silastic. They make these sort of hinged implants that can function as a small joint replacement out in the fingers. So the nice thing about these again is that it can provide some pretty reliable pain relief while also preserving good motion of the fingers compared to an arthrodesis or a fusion procedure. As you get out to the end of the finger, to that last knuckle in the finger, what's called the DIP joint, I see lots of patients with arthritis in this knuckle. Very few of them end up needing surgical treatment. The patients that typically end up having surgery are patients like this patient with sort of bone-on-bone arthritis, severe pain, and oftentimes sort of deformity or angulation of the fingers. And these are treated just with a screw down the middle of the bone from the tip of the finger, and basically sort of correcting the malalignment at the same point in time. So the last condition I'd like to talk about is Dupuytren's disease. Not everybody's heard of this, but it's a fairly common thing that I see in my world. Dupuytren's is a genetic condition. It's common in folks of Northern European descent. All of us underneath the skin in our hands, we have a structure called the palmar fascia, and it's this sort of thick fiber structure. It's what keeps the skin on your hands from sliding around when you grip things, keeps you from dropping things. For patients with Dupuytren's disease, they make extra palmar fascia, and over time, that palmar fascia can sort of grow and coalesce and cause the fingers to draw down or contract. It's typically a painless condition, but for patients with more severe contractures, it can really be a very functionally impairing thing because they're unable to get the hand open to get into a pocket or put a glove on or get around a larger object, that sort of thing. Typical progression of Dupuytren's disease is illustrated here. So many patients start with just a lump in the palm or several lumps in the palm, what are called nodules. And over time, those nodules can coalesce into these kind of rope-like structures called cords. And as the cords become more mature and larger, they can actually cause the fingers to draw down or contract, like you see there on the right. This is not usually a rapid process. There's often years, if not decades, between these stages, so it's a disease that tends to come on slowly. So treatment for Dupuytren's disease is listed there on the left. For most patients, especially patients with just nodules or cords without associated contracture, then the recommended treatment is just observation. For patients who have more severe contractures, then we may need to consider one of these other three options. So you see John Elway there on the right, and you may be wondering to yourself how John Elway made it into this talk. Apparently Elway has Dupuytren's disease, and he's been making commercials on behalf of a company called Endo Pharmaceuticals that makes an injection called Xiaflex or collagenase. So what Xiaflex is an injectable enzyme. You inject directly into the Dupuytren's cord, and over 24 or 48 hours, that enzyme kind of chews up or digests the cord enough that we could inject some local anesthesia and the finger in the office. It works well to cause cord rupture, but it's expensive. It's in many cases, $3,000 or $4,000 a dose, and about 10% of patients will have some sort of a side effect or a systemic reaction to the collagenase enzyme. So it's not something I use as much in my practice as some other physicians. For patients with Dupuytren's disease who are looking for a minimally invasive option, typically what we'll talk about is a procedure called needle aponeurotomy. So what needle aponeurotomy is, you can see a picture of a patient with Dupuytren's there with contracture of the small finger. What needle aponeurotomy is basically, it's an office-based procedure. Patients come in, we inject a little local anesthesia, a little numbing medicine around the cord. And then if you ever look at the end of a hypodermic needle, it's actually got a little bevel or a little blade on the end of it. So we actually use sort of a small needle as kind of a percutaneous knife, and use that needle under local anesthesia to mechanically break up or disrupt the cord and then straighten the finger in the office. It's a really nice procedure because it comes with no downtime, and I have a lot of patients who are really happy with it. So you can see these two preoperative images, and then this is an immediate post-op image of the same patient. So just a couple of little nicks in the palm here with a needle, just a simple Band-Aid, and then almost complete correction of the contracture. So for some patients, though, these minimally invasive treatments for Duplitrons are not an option. In those patients with more severe contractures or broader cords or just things where the less invasive procedures are not as safe, the gold standard has been for many years is a procedure called a pulmonary fasciectomy. We make a larger skin incision and basically go in and remove all of the skin or all of the diseased tissue. The incision may be a little bit intimidating, but patients actually recover quite quickly from this procedure. Stitches come out at 2 weeks, and most folks are more or less back to normal by 4 or 6 weeks. Of all the things we can do for Dupuytren's disease, this procedure provides the most durable and sort of longest lasting correction of the contracture. So that brings me to the end of my prepared material. You can see the topics that we covered here this evening. I appreciate your time and attention, and I hope I provided some useful information. So I'd be happy to take any questions that you have.
Hey, Dr. Potter, this is Sarah. Sorry, there's some feedback. One of the PAs here. I have a couple questions that came in that hopefully you can hear me and everyone can hear me. And anybody on the computer, you can open up the Q&A and ask further questions if you have them for Dr. Potter. So thanks for that. That was helpful. One of the questions we have is, how frequent is it that you see recurrent carpal tunnel?
Not very often. So for most folks, I would say upwards of 90% of patients, carpal tunnel is sort of a one and done operation. There are kind of three broad categories of patients that have persistent or recurrent symptoms after carpal tunnel release. Sort of category one, I would say this is probably least common, are folks that have basically an incomplete release at the first procedure. So those are patients that the transverse carpal ligament, for whatever reason, doesn't get completely released, and so the symptoms persist. Very uncommon. The second group of patients are patients that form a lot of scar after the surgery, and again, we're talking less than 1 in 100 or less than probably 1 in 200 that have any major issues with that, and there are treatment options in that situation. There is a small group of patients that, and this is what I see most commonly when I see patients with recurrent carpal tunnel syndrome, there'll be folks that develop carpal tunnel symptoms early in life, in their 30s or 40s, and had a carpal tunnel release, and then over the next 2 or 3 decades, for whatever reason, develop recurrent carpal tunnel symptoms, in their 60s or 70s. And if you go back and operate on these folks, I mean, the ligament has essentially completely reconstituted. It looks like they've never had surgery at all, but all three of those are very uncommon. Most patients who have a carpal tunnel release never need another surgery on the median nerve.
Great, thanks. One other question came in from somebody who has had a distal radius fracture or a wrist fracture, and she is wondering if we do anything to help prevent fractures, and if you can speak to that just a little bit.
Yeah, I think that's a great question. I think one of the wonderful things that we have here is we have a fracture prevention service, essentially. So we have a couple of the PAs that work in the office here that will do the lab work, we'll do the DEXA scans, and then we'll do counseling with patients about what measures they can take, whether they be exercise, whether they be dietary changes or vitamins or medications that can sort of quarterback or guide patients through the process of keeping their bones strong and healthy. So I think that's a great service that we offer.
Great. And then speaking to the wrist arthritis, question about PRP and how effective it might be, should be considered in the sequence of treatments.
So that's a great question as well. To my knowledge, PRP has not been studied as extensively in the hand and wrist as it has for some of the larger joints, for knees or hips or shoulders. I may in some ways actually kind of defer that. I think there may be a role for it. I know Dr. Pevney has a talk coming up about various different kinds of injections, and I would expect he would cover that to some degree. Like I said, it hasn't been studied as much specifically in the hand and wrist as it has in some of the larger joints, but I would expect that you can sort of generalize some of that data to this area as well.
Great, and then the last question, and maybe it's just kind of a general question about the basal thumb arthritis procedure. This person's asking if you use bone grafts, but maybe even just talking about some of the different techniques that people use compared to what you do.
Yeah, so basically, there are a number of described variants of surgery for arthritis in the basal joint of the thumb. The element that all of them have in common is that arthritic trapezium bone comes out. Where they differ is in how people choose to keep the thumb suspended or to keep that space open where the bone came out. Historically, what's been done, and this is probably starting in the 60s, and there's still folks doing this, is a procedure what's called an LRTI, or a ligament reconstruction and tendon interposition. And basically what that historical procedure involves is harvesting a tendon, the FCR tendon from the forearm. And then that tendon is sort of weaved through bone tunnels in the base of the thumb, and usually partially split, and part of the tendon gets stuffed into the wound and part of the tendon gets weaved through the base of the thumb. It works well. It just is, it's a little bit more of an extensive surgery than the procedure that I do. What I do is a procedure that was described by a female hand surgeon, Dr. Del Signore, and I think it's a really elegant procedure. So same idea, trapezium comes out through a small incision at the base of the thumb. And then once that trapezium's out, you're looking at the FCR tendon at the base of the incision, but rather than harvesting that tendon in the forearm, just leave that tendon as it is. And what she does and what I do is you just take a big heavy stitch or a big heavy suture and suture the FCR side to side with the other tendon that's in the neighborhood, a tendon called the APL tendon. And what that does is it sort of draws those two tendons together so that they make a little sling or hammock underneath the base of the thumb. And that holds the thumb in position while it heals, but it doesn't involve additional incisions. It doesn't involve, drilling tunnels in the base of the thumb. And so I think it's a little bit easier and a little bit faster recovery, and it doesn't burn any bridges.
Okay, great. I think that was the last one. So thanks again to everyone for attending. Thanks, Dr. Potter, for such an informative talk. And if there are any questions, feel free to send them through the Q&A, and we can always answer them now, even after the talk, or we can send you an email. The next talk that we have coming up is on August 4th with Dr. Leota. He's going to cover shoulder pain. So feel free to sign up. You will receive a little prompt for a survey after this talk. And we encourage you to communicate with us and just let us know what would be helpful for you to hear in the future, because we're trying to make this an ongoing thing every month. If you have any questions, feel free to reach out to our office.
Thanks, everybody. Have a good night.